Hello and good evening, everybody, and welcome to another webinar that we have. We have the fortune of being able to present these every so often as regularly as possible. And we have another wonderful webinar for you all tonight. My name is Michael York, and I will be your moderator for this evening. And if you do have any questions throughout tonight's presentation, go ahead and hold on to those or submit them to the question and answer function down below or the chat function. We'll be sure to address those at the end, just in case Dr. Rouhani happens to answer those questions for you as tonight's presentation goes along. But yeah, be more than welcome to submit those down below. If we can stay away from the raising of the hand function, it takes a little bit of technical expertise. So we try to trend away from that. So the question and answer in the chat function will be perfect for tonight's use. We are so very happy to have a wonderful webinar, Cornea Considerations for Cataract Surgery, presented by our very own Dr. Behnaz Rouhani. Dr. Rouhani specializes in cataracts, cornea, and refractive surgeries with Harvard Eye Associates, and we're so thankful that she could spend some time with us this evening and going over some of these considerations. Before we delve into tonight's topic, just a little bit of background about Dr. Rouhani, who received her medical degree with high honors from Shahid Beheshti University of Medical Sciences and conducted her clinical research fellowship in ophthalmology at the Rocky Mountain Lions Eye Institute at the University of Colorado. After her time in Colorado, Dr. Rouhani completed her ophthalmology residency at Drexel University College of Medicine in Philadelphia, and followed her residency with a fellowship in cornea and refractive surgery at Ross Eye Institute, the State of University of New York. So we are so very thankful she can join us this evening. And without any further ado, I will pass things along to Dr. Rouhani.
Thank you, Michael. Good evening, everyone. Welcome and thanks for joining us tonight on this topic, which I think a lot of patients are very curious and very interested to know more about why we do cataract evaluation sessions or visits with them and what does that cataract evaluation appointment is all about. So I will walk you through the most important parts that we need to, as surgeons, really be careful and look for to provide all of you with the best vision potential following cataract surgery. So the goal for preoperative eye examination is to find and address any potential issues that could affect the visual quality and surgical outcome before surgery. This is very important because some of the conditions could potentially be more asymptomatic or on the milder side before surgery, and cataract surgery itself could be associated with very transient kind of like discomfort of the eyes after surgery when patients get surprised about it, that they never had it before, for instance, and they would like to know what happened. And everything happened after cataract surgery. Nothing was told prior to cataract surgery that they had issues when those conditions are on the milder side. So these are very important, and I will walk you through what examples I have for you to know about those conditions. Other goals are to optimize visual outcome by proper management and treatment of cornea conditions and overall eye surface health prior to surgery. And again, I'm stressing out on prior to surgery because it's very important to address those issues and prepare the eyes for surgery to achieve the best outcome. Type of the lenses that we implant when we remove the cataract from the eyes are very important. There are tons of different, these days, because of the technology era that we live in, we have a lot of different beautiful lens implants and technologies out there. However, not every eye can take that. So it's very important to know about the general eye health condition prior to making a decision of what type of a lens implant we should give to our patients. And also to determine when to proceed with cataract surgery to achieve the best visual outcome. Again, I'm stressing out on the visual outcome following surgery because our main goal for cataract surgery is to provide the best vision potential. And when to proceed with cataract surgery is important because the eye needs to be prepared for that. So I'll walk you through a very, important and mostly common things that we encounter on a daily basis in our patients prior to cataract surgery, and the ones that can affect the visual outcome. Just to walk you over the anatomy of the eye, which is very important to understand what's the cataract surgery involved, and what's cornea. As you can see, the very clear layer and very front part of the eye is cornea, where I like to refer to as the window to the eye. It should be a clear tissue that lets the light gets in. Then we have the color part of the eye, which is called iris. Behind the iris, the lens is located. Our lens is naturally clear, and as we age, it gets cloudier or yellowish coloration to it. And then as the time goes by, and if it is left untreated, it can get darker yellow, brown, and white, which these days we don't let that happen anymore. We take care of that sooner than later. And then the retina and the optic nerve. Each part of the eye is very important in terms of how we see. So part of the cataract evaluation is to ensure that every part that I showed you is functioning well, apart from the cataract. So therefore, meaning changes in the vision is not necessarily just secondary to other parts of the eye, but just the cataract, then we'll proceed. Or if we find out that there are other existing conditions going on, we address those before proceeding with cataract surgery. Again, another image that it's shown here, this is a cornea, which is a clear part of the eye, very front, the window to the eye, then there's a color part of the eye, and the lens. This is a magnified view for you to understand better where the cataract is located. As you may all, or most of you may know, because this is such a common condition these days, is dry eye and eyelid margin disease. A lot of patients are already dealing with it, or they have a mild kind of like stage of it that needs to be really addressed prior to cataract surgery. Ocular surface, which means the tear film that covers the surface of the eye, is very, very important to be assessed and managed prior to proceeding with cataract surgery. Lid disease means any sort of a lid problem, including the positioning of the eyelid or the condition of the glands that are located in the eyelids and they open up right behind our lash line. Are they really working well or not? Those all affect the outcome of the vision and comfort after cataract surgery. So therefore, ocular surface and lid disease are correlated with worse contrast sensitivity and also the quality of the vision if they are left untreated. So we need to really address those to provide the best visual quality after surgery. This is an inverted kind of like flipped eyelid that is showing where are meibomian glands, which are oily glands, located. And these are in charge of producing the oily part of the tear film to keep the tear film nicer and heavier against gravity, longer lasting on the surface of the eye, rather than losing it as a watery tear film. This is where we have some dysfunction of those glands where they cannot get the oily part out to the tear film. And there's a tool here that I'm trying to kind of like press on those meibomian glands and express that sort of an oil. In some patients, you can express. Some patients, they have more severe and more, advanced stage that just gentle pressure, it's not going to let those release the oily part of a tear film. So staging of the condition is very important, and addressing this condition is very important to make sure that we have a nice protective shield of tear film on the surface of the eye to improve the visual acuity after surgery. Management of dry eye is very important prior to surgery. So depending on what's causing the dry eyes, because we do have multifactorial reasons behind dry eyes, very important to address what's exactly causing it. So if there is a water part of the tear film lacking from the main tear tear gland, we're going to address that. So lubricants are, generally speaking, commonly used. They are good for symptomatic relief, but they're not treating the underlying condition. However, we want to start patients on those to get the surface of the eye more lubricated and the cornea health better shape before we do the pre-op testings. Punctal plugs are used to be placed in the tear draining system. Therefore, we can hold on to our own produced tear film longer on the surface of the eye and less of a dryness. Anti-inflammatories or steroid drops are commonly being used specifically prior to surgery to get the eye ready for the surgery and calm down any inflammatory factors that could be causing the aqueous deficiency and dry eye disease. Evaporative dry eye disease can be seen in the setting of meibomian gland dysfunction, where I showed you how those oily glands were not able to release the oily part of a tear film. Therefore, the tear film evaporates too quickly because of lacking the oil. So what we try to do is thermal therapies, including warm compresses, to some laser procedures that we have. I always recommend lid hygiene because it will take away all the dead skin and bacteria that are right behind our lash line, blocking those glands and not letting the glands do what they're supposed to do. So always lid hygiene is the very baseline, but very important part of a treatment to be started, followed by warm compresses to get the glands working and doing a better job in terms of providing a better quality tear film. And so as topical anti-inflammatory drops or ointments. Then the lid pathology, as I just briefly mentioned, is very important to be assessed as well. If we have problem with closing the eye completely at night and when we are sleeping, or we have loosened eyelids due to aging, then we would like to do something to help that part of the eye that is going to stay open throughout the night being protected against exposure to outside and get really dry. So nocturnal lubrication with ointments and gel drops can help. Lid tightening and repair procedures are considered. And one very important thing is sleep apnea evaluation, because those patients with sleep apnea can easily get anatomically changed eyelids or floppy eyelids that can evert while they sleep, especially if they are side sleepers. So they go to the pillow and then the eyelid would evert or flip and the eye surface will get really irritated and dried out. So these are very important to be evaluated and managed prior to cataract surgery. In terms of how we do lid hygiene, we do have wipes, we do have sprays, we do have foams. One of the very most commonly used ones are OcuSoft lid scrubs. I do not have any financial disclosure with anything that I'm going to be talking tonight. It's just like the stuff that I have been using and I've been seeing really results in my patients. OcuSoft lid scrubs, there are pre-made, prepared kind of like wet wipes that you use on your closed eyes, remove any dead skin, any bacteria, washing it, rinsing and drying, followed by warm compresses. There are different types of warm compresses. There are the ones that you can put in a microwave, warm it up technically for about 20-25 seconds, not to make it too hot, but just warm to put on your eyes and make the glands work for you better and open up. The electrical versions are available. They're more practically used. Sometimes I see my patients really forget to use the ones that they need microwave. So the electrical versions are much more helpful because you can put it on your nightstand or where you can see them more and just plug it in, put it on your eyes. Here it says 20 minutes because this sort of eye heating mask it keeps at 20 minutes and starts going backwards. You definitely don't need necessarily to put it on for 20 minutes, but at least 5 minutes of consistent warmth is really required to get those glands working for you better. And then preservative-free artificial tears, sustain, refresh, there tears, blank. I would go with preservative-free because preservatives themselves can cause some irritation of your eyes, and preservative-frees you can use as many times as you need, as opposed to those which are in bottles and they have preservative, should not be used more than 4 times a day. The key points here: compliance to treatment regimen is the key. I usually give my patients an instruction sheet and I say, okay, go by this, please, and get this done, especially if you're deciding to proceed with cataract surgery or any surgical procedure on the eye. Compliance is the key, because all of these things together will work best to get the glands and the health of the eye in general be at the best state possible prior to surgery. I will give my, ladies a makeup holiday too, to get those glands working better and staying nice and clean. And one of the things that can help is minimizing prescription drops post-surgery. These days, we have the beauty of having the antibiotics in the operating room to be given in the eye while we do the cataract surgery, and also putting a little bit of a plug, which does have steroid in it, to minimize the amount of drops after surgery, because drops, because of most of the preservatives in them, can irritate the surface of the eye and cause more of a dryness and problem after surgery, and irritation and discomfort. And last but not least, it's very important to do exercise, hydrating yourself, and healthy nutrition, of course, with best oily kind of like nutrition out there, such as fish oil, omega-3s. I'm more of towards a natural sort of a thing. So avocado oil, olive oils, avocado and olives themselves are very, very helpful too, but not by themselves only. Everything all come together when they are being done. Recent reports have been shown walking and maintaining a good exercise level will help with the dry eyes as well. All right, so the next thing that we really need to evaluate for prior to cataract surgery is what we call epithelial basement membrane dystrophy. This is a genetic condition that can be seen on the cornea. Sometimes it's very faint, but we need to really be careful and look for it with certain lightnings on the cornea to see, you see like some sort of a map and linear like opacities on the clear part of the eye, which is the cornea. And those can cause a little bit of a lumpy, bumpy surface, meaning they can give you irregularity or astigmatism. So I kind of like went over what it already is and what do I do before cataract surgery. When these are causing a lot of irregularity, it would be best to remove them and remove the surface, make the surface clear prior to proceeding with surgery. The reason is that these can cause a lot of contrast and glare issues after surgery if they are not being addressed. The other reason is that sometimes they cause astigmatism that by removing it prior to surgery, then we won't be in need of moving forward with more premium or toric or astigmatism correcting lenses after surgery. So what I usually do, these are minor surgeries. I remove the superficial layer of the cornea. In the operating room, it is so minor surgery that sometimes it could be done in the office setting as well. Once the surface is removed, the surface is going to be covered by a bandage contact lens to help with the healing process. And then patient is going to be placed on cool preservative-free artificial tears. And a week after, we see the patient. Usually a healthy cornea regenerates itself after 7 to 10 days, and patient should be fine. However, in order to when to proceed with cataract surgery, we usually have to wait for 8 to 10 weeks following surgery, making sure the cornea is stable and the readings are stable on the cornea in order to get all the measurements prior to cataract surgery accurately enough to get us to the best lens power possible to provide the best visual outcome. These are some cornea mapping pictures. So the case that you saw with the picture I showed you, this is the mapping of that. Usually with the normal cornea, we see mostly green. When you see other colors, that means that the surface is kind of like irregular, or there are some lumpy, bumpy surface giving you astigmatism. This patient had about over 1 diopter of astigmatism prior to surgery. You see blue areas, you see red areas. Blues are flatter areas. The red are more steeper areas, technically a more kind of like irregular surface. About 6 weeks after surgery, you see everything is more universally kind of like dispersed over the cornea. The cornea is looking more regular, and the astigmatism level is about 1 diopter less than what it was before just the superficial keratectomy or just this removal of the surface of the cornea. And then 9 weeks after, which is 3 weeks after 6 weeks that we want to check and make sure we have to at least have 2 topographies or cornea mapping showing the stability of all these numbers and astigmatism level before we proceed with cataract surgery, in order to make sure all those pre-op exams that patients go through will give us the best accurate numbers in order for us to choose the lens power that it's perfectly giving you a good visual outcome. The next topic that has been pretty common these days, and I see them mostly as a cornea specialist. I'm biased because they send those to me a lot. But anyway, this is something that any ophthalmologist, no matter whether they are cornea specialists or not, they need to look for it prior to cataract surgery. And it's Fuchs dystrophy. Again, it's a genetic condition. It's inherited as an autosomal dominant pattern, mostly, I should say, and sometimes sporadic. What does that mean? That means that those who have it, they have to have their kids being checked out once they reach 50 or older age, because you have 50% of chance to give it to them. It is a disease of the cornea cells, inner cornea cells, deteriorate, causing cornea swelling. The inner cornea cells are in charge of pumping out fluid from the cornea tissue, keeping the cornea tissue pretty nice and clear. Once they don't pump out fluid from the cornea becomes swollen and the vision will be deteriorated. This can lead to blurred vision, eye discomfort, and also if we don't really pick them up prior to cataract surgery, and then we will see cornea edema after surgery, or cornea swelling after surgery that is not going away. We need to suspect that and check that out. It helps us, first of all, it affects both eyes, and it is a progressive condition. It gets worse over years. And treatments range from saline drops that we give, because saline drops have salt in it, so it absorbs extra water that's retained in the cornea. There are saline ointments too that patients can use them at nighttime. And in advanced cases, cornea transplant surgeries might be needed. So how they look, so this is the thickness of the cornea. This is the light beam showing all the layers of the cornea, and then in the very inner or deeper layer of cornea, you see this metal sheen of those cells that are not really working well. They're not supposed to look like that. So if you see it in this picture, the central ones, they have that metallic sheen, but the more superior or upper ones are not really looking that bad. And this is what it causes. So they cannot pump out enough fluid from the eye, the cornea, therefore the cornea becomes swollen. You can see some swelling about here. This gives like a little bit foggy or blurry vision to patients. Sometimes it's so subtle that it doesn't cause any sort of cornea swelling, but knowing it is going to help the surgeon to prepare few extra steps during the surgery to prevent cornea to lose further cells following surgery. So this is another kind of like a test that we do to look at how the shape of the cells of the inner part of the cornea, or endothelial cells, are. And this is how they should look normally. And this is when the endothelial cell dystrophy happens. So that shape will be gone. The cells could be looking differently. There are going to be some areas without any cells, or what we call cell drop. So staging of that disease is very important too, in terms of making a decision on how to proceed with cataract surgery and what to do. Why do we need to look for it? Again, I kind of like briefly went over it already. So this helps with choosing a surgical technique to protect the inner cornea or endothelial cells as much as possible. So we do a few things here and there, a little bit more. And also we make sure that we don't stay in the eye long enough, because the more we stay in the eye while we're doing the cataract surgery, or if the cataract is so dense, it could put potentially those cells at risk of decompensation or further cornea swelling after surgery that cannot recover. And one of the most important decisions is that depending on the stage of Fuchs dystrophy, we can make a decision on whether a patient would benefit from combined transplant and cataract surgery, or we can stage the surgery, start with cataract surgery, see how patient recovers from cataract surgery, and if cornea cannot recover from swelling, then we can move on to transplantation. How we transplant is out of the scope of tonight's talk, but we'll talk about that, not too long from now in the near future. And also setting a realistic expectation of how cornea will heal after the surgery, and type of the implant. The lens implants, again, are very, very important to be discussed with patients to set a realistic expectation of what we are looking after surgery. And when we know there is such a thing, certain premium high technology lens implants are not a good, case or candidate for this implant. So it's very important to know to not put those implants in the eyes. Otherwise, we need to go back and remove them and put a very straightforward standard kind of like lens implantation. Premium lenses such as light adjustable lens, however, are an option. The light adjustable lens is an option when combined cataract and transplant surgery is done. So if anyone has a question in regards to, okay, what if I go ahead and having an advanced stage of Fuchs dystrophy and I have cataract too, I was told that I have to have the combined surgery, can I get a premium lens to optimize my visual outcome? The answer is yes. But the only one that is approved right now to be kind of like used and implanted in patients with Fuchs dystrophy and transplants is the light adjustable lens. That's the higher technology lens that is available now and is FDA approved. Other than that, the extended depth of focus implants or trifocals are not recommended. And again, all of that is because of the contrast changes and a lot of other things that can affect the visual outcome. This is a picture of a patient who has Fuchs dystrophy, and you can see just the clear part of the eye. The cornea, which is supposed to be clear, is now a little bit grayish and foggy and swollen in this area. You might see that there are little bubbles of fluid here, there are blister type of thing. When the cornea cannot get rid of the water, it builds up some blisters or some bullae, what we call, which kind of contains a lot of fluid in there. It makes it foggy, so patient at this stage knows that they're looking through a fog. Also, there is like a yellowish hazy lens in there too. So this case, when it gets to this point, it's kind of a pretty advanced case. We know that we do cataract surgery, this cornea cannot take it. So it would be best to do a combined surgery. This patient had a combination of cataract surgery. You see that center is now so clear, and also cornea is so clear that you just see technically the color part of the eye, but there is a nice and clear shield in front of it. And that's the cornea transplanted tissue. Just one layer though, not the whole cornea. So what we these days do for patients, the beauty of the transplant surgeries these days is that we don't need to remove the whole cornea. We just go in the eye and then remove the inner endothelial cells and replace it with just one layer donor tissue. And you can see this patient after 3 weeks is just like nice and clear and everything looks great and the vision is much improved. So staging of the Fuchs dystrophy, knowing it prior to cataract surgery is very important to make us move on with either the stage surgery and also, or, combination of transplant and cataract surgery. And also it helps us with decision on what type of a lens implant we should put in patient's eye. All right, so I think I actually have discussed any questions here that I can answer before we go to the next topic. We're good, Michael?
Yeah, it looks like as of the moment, we have no questions.
Okay, all right, perfect. So Salzmann nodular degeneration is the next condition of the cornea that is, again, very important to look for prior to proceeding with cataract surgery. This condition is a slowly progressive condition. It actually is associated with grayish, whitish, elevated nodules or bumps on the cornea. Risk factors are ocular surface disease, and again, those who have long-term dry eyes, meibomian gland dysfunction, blepharitis, those topics that we already covered, they can develop these rough spots on the cornea over time. Those who are contact lens wearer and they keep their contacts in for too long of a time are at risk of developing Salzmann nodules. History of cornea infections can put patients at risk of developing these nodules. Trichiasis is a condition that the eyelashes grow inwards rather than outwards, causing a little bit roughness on the surface. So that's another thing that can cause this issue. Previous traumas, Crohn's or autoimmune conditions have been shown to be associated with Salzmann nodular degeneration, and of course, genetics could play a role. Sometimes patients, they don't have any of these, but we see them in their eyes, so it could be idiopathic or genetic sort of source. Diagnosis is usually made just by looking and doing the examination clinically. As I showed you in that picture, they're usually gray-white to bluish nodules on the cornea. Sometimes when they get bigger, they can cause a lot of foreign body sensation and irritation to patients. Corneal topography or mapping can show a lot of irregularity or astigmatism that patients will notice by changes in their vision. Corneal scarring can happen, visual changes, glare, foreign body sensation, as we talked. And medical management is usually with lubrication, making sure that we keep the eyes nice and lubricated. Steroid drops can help with minimizing the elevation at times. They're not going to be regressed, though. Warm compresses can help, again, just to keep the surface health of the eye. And of course, the proper eyelid hygiene. Another thing, this is another case that we do superficial keratotomy or removing that surface of the cornea to make it nice and smooth and help the cornea regenerate the surface itself to be less lumpy, bumpy technically, and less irregular, reducing the amount of astigmatism in order to improve visual outcome. And this minor surgery itself will provide improved visual acuity in most of the cases. PTK, the laser procedure or amniotic membranes, which we process them at eye bank, right? Donated placentas, they have a lot of healing factors and can help with the improvement of the Salzmann nodules and to achieve the nice surface and eventually optimal visual outcome. How is this condition going to affect the cataract surgery outcome? So again, as we talked about the other ones, the lens choice and necessity of astigmatism correction is really based on how much these nodules are causing issues for patients. So by doing those pre-op examinations and testings, we can determine whether Salzmann nodules are causing too much of astigmatism rather than cataract itself. Therefore, we're taking care of those, we can minimize the astigmatism and unnecessary astigmatism correction with cataract surgery. They can affect the contrast sensitivity and glare. So let's say we don't remove those and we put a cataract and we do the cataract surgery, put a lens implant And there are sometimes it can give the patient almost 20/20 vision, but they're not happy because of the contrast, because of a lot of blur, because once the light hits those nodules, it scatters. And no matter how much the inside of the eye is now clean and clear, they are not happy with the quality of the vision. And that is one of the reasons that most likely is not taken care of. And we can take care of that prior to surgery to improve the outcome. This is a patient of mine that I had with a huge area of grayish nodule that you can see that actually extended on to the center. And this patient needs cataract surgery. And I said, well, you know what? This is elevated. This is causing a lot of issue. I did topography or cornea mapping, showed a lot of astigmatism causing by this, which I show you in other pictures. I guess I have it in the next slide. And then I did superficial keratotomy, which meaning I always tell my patients, like a scab on the skin, I'll go underneath the scab, remove the scab, make the cornea, regenerate the surface. It's going to regenerate the surface. Surface is going to be nice and clean. And you can see how good you can see the center. And also everywhere in the cornea is looking nice and clear with no bumpy, lumpy, foggy, cloudy spots. This is a topography I did prior to the surgery. Look at the mapping. You don't really need to learn what this is because you can look at it and see, okay, you can see ocean, you can see a lot of mountains. So it's a lot of rough, kind of like or irregular surface. And when you look at all these mires, you can see like some of them are circular, but then as you go further out, they're very irregular and not circular anymore. And this is, so we call this kind of like a crab claw-like pattern causing a lot of irregularity or astigmatism for the patient. And then after surgery, when it's done, see, there is no ocean or mountain anymore. There is just nice and smooth surface, and all these mires are nice and circular. So not much of an astigmatism left for this patient. The patient was already happy, or just like a little bit of a contrast, residual contrast problem that we ended up doing the cataract surgery. So those are very important to not miss. Okay, the next thing is pterygium or surfer's eye. Well, this could be known to a lot of Californians, I should say, because we're a state of sunshine, and this is caused by a lot of UV light exposure. A little bit of a growth on the white part of the eye, which is raised, wedge-shaped, and it's benign. Usually this is not really looking, malignant at all. So it's just vascular, thick tissue because of UV light affecting conjunctival or clear layer that it's covering the white part of the eye. Again, long-term exposure to UV light is the main cause. And it is a progressive condition, and it can kind of like progress after surgery too. So we want to take care of it sooner than later for a wide variety of reasons, not only to improve visual outcome after cataract surgery, honestly, but also to help with the cornea health as well. The more it actually grows over cornea, the higher chance of cornea scar tissue formation after surgery, not after surgery, just overall, but also after surgery. So the outcome of the vision quality is what matters. And I usually do like to remove these prior to cataract surgery. I've seen some of the colleagues, they don't, because they go by how much this is giving the, the irregularity of the surface a little bit more, to the advanced stage or not. I do like to remove them prior to cataract surgery because once the patient comes over for pre-op examinations, I have a nice clear cornea, where those pre-op testings will be more accurate, number one. Number two, this is a progressive condition. It will get worse. So patients might be happy after surgery if I don't get this done, but that happiness may last only a few years and they start having problems once this progresses. So it's always better to be done prior to cataract surgery. The next condition that some of you might know about is radial keratotomies. These procedures, just like is an outdated surgery, we are not doing it for a couple of decades now, I guess. These were done in 1990s, as far as I know, where radial incisions were made technically to make the cornea flatter and address the nearsightedness for patients. Why is it important to, catch them now? I mean, we're going to catch it. No one is going to miss radial keratotomies on exam because they're really nice, fairly cut, incisions. But why is it important to know about them, to evaluate them? Because we need to use different calculations, different modalities to pick the lens and also the power of the lens that will give patients better outcome. Lens selection is challenging in these cases because with the standard lens calculations, we could be a little bit off. So, and because of how these incisions can affect the curvature of the cornea and also the effective lens position, which is very important in calculations. Thankfully, there are some additional methods out there right now that we can improve the accuracy, but it's always a little bit of a chance of patients having difficulty or discomfort after cataract surgery with their vision quality. Multifocal implants or premium implants have not been associated with a good outcome and are generally not recommended until we got this light adjustable lens approved as of December 2020, which is a premium lens that is now available. And it's beautiful because no matter how much we are off with our calculations now, we can adjust this lens after cataract surgery to the best vision quality that patient kind of like wants to have. A little bit about light adjustable lens I need to tell you about is that with light adjustable lens, your vision can be customized after cataract surgery. So it's very, very, very helpful in those patients with radial keratotomies, with difficult kind of like corneas, other cornea conditions that such as cone-shaped corneas or keratoconus, which I'm going to talk in a little bit about that. These are amazing lenses because we can treat the lens after cataract surgery to provide patient with the best vision potential that they are deserving to have. They have the unique ability to adjust and preview your vision based on each patient's personal desires and lifetime requirements. And the optimization is done by your ophthalmologist, your surgeon, after lens implantation through a series of office-based procedures. I mean, the procedures are called procedures, but I always tell my patients these are not procedures. They're just like, you're going to sit at the slit lamp-like machine, and then we're just going to treat that lens with a little bit of a bright light, which is the UV light, for a few minutes. So this is the machine that patients sit here technically, and then the surgeon sits here. There are all the settings over here that we see. We'll look through your eyes through these, and then we shine a UV light based on what we need to do for you to give you the best visual outcome, which our optometrists check that out for you, and then we put that in the machine. We set it up in the machine, we give it with the UV light. The UV light will reshape the lens to a point that you can have your customized vision. And it's the only available FDA-approved implant that we can do that after surgery. So keratoconus or cone-shaped cornea is another one that makes kind of like cataract surgery decisions a little bit more challenging. And keratoconus is cone-shaped cornea. Cornea usually has a very nice and regular curve shape. In keratoconus patient, you can see that cone-shaped cornea. So the steepness at every part of the cornea is not the same. Usually they have more steeper in the bottom of the cornea and flatter on, up top. The cornea mapping shows really irregular shape, astigmatism, more steeper in the bottom part of the cornea. Again, this can cause moderate to severe astigmatism. Lens selection is going to be challenging, again, because of the cornea curvature. And stability of this condition is very important before we move on to surgery. Most of the patients, when they develop cataracts, they already have the keratoconus stabilized because keratoconus doesn't really progress after early 40s. But still, we need to make sure that the condition is stable before we move on to cataract surgery. In terms of implants that we can consider in keratoconus patients, again, multifocal ones are not really recommended. We can use toric or astigmatism correcting lens implants to reduce the amount of astigmatism for patients, or light adjustable lens in cases with milder amount of astigmatism, because with light adjustable lens, we can treat up to a certain amount of astigmatism for patients. But both are amazing lens implants to help patients to have the best vision potential. Corneal scars are important to be evaluated. Knowing the history, not only medical history, but eye history is very important and very crucial before we move on with surgery. History of shingles in patients and herpetic infections are very, very important to know, because shingle virus and herpes virus are viruses that are not going to ever die. They're going to go to a dormant and sleep stage technically, and they wait for a stress or some kind of like lower immune system to wake them up. So knowing the history of those is very important. Sometimes the type of the scar will lead us towards suspecting such history in patients. So they are recurrent, they can flare up, especially after surgery, because surgery is already a stress to the eye. And again, preparing the eye and the patient actually prior to surgery is very important. And how do we prepare? Once we have a scar, we have a scar. We can't do much about it. We can by doing, again, cornea transplant surgeries and stuff. But in patients such as this patient, which has a scar away from the center part of the vision, we still can do cataract surgery and improve vision. However, in order to prevent the chance of flare up or waking up the herpes virus or shingles, we need to prepare a patient. I usually put my patients on treatment dose of antivirals a week prior to the surgery to prepare the body for the stress of the surgery. And if I have a patient who just recently recovered from a herpetic eye disease, I wouldn't proceed with cataract surgery. At least up to 3 months of making sure the eye stays nice and healthy without recurrences. And that's another reason I put that here, because I want you to always share your eye history with your surgeon. Sometimes we might not see as big of a corneal scar as we see now. It just could be very subtle. Sometimes nothing is there, but knowing your history is going to help us knowing and making better, decisions. And last but not least, cornea or eye surface tumors. Thankfully, these are not as common these days, but they are associated viral, infections and UV kind of like exposure too. So these could be seen as a growth, strawberry-like features, whitish growth that is extending on the cornea with some bad tortuous vessels. That these are kind of like feeder vessels, meaning they're feeding the lesion to grow more and more and over time. Sometimes patients feel they are just like the growth, have been having them for a while. They feel they may be surface eye or pterygium, but they are actually not. So evaluation of these, further digging into what's the potential reason and cause, is very important prior to cataract surgery. Again, we talked about that part. Medical history, including skin cancers, also help us knowing more whether the patient is prone to have those sort of similar sort of skin cancers on the eye surface too. And management and treatment prior to cataract surgery is advised. Again, not only because this is like, let's say this was a patient of mine actually, had this lesion grown over cornea. This patient came to me for cataract evaluation. I'm like, well, we have to take care of a few things prior to proceeding with cataract surgery. And the good news is there are treatments for these, even topical treatments. There are beautiful eye drops out there that we can use to help shrink the lesion. And if it doesn't work, we can go ahead and remove them prior to proceeding with cataract surgery. Why not cataract surgery first, even though the center is nice and clear? Because growth over here can again affect the surface regularity of the cornea and throws us off when we do all those calculations. The lens calculation is not going to be accurate. The vision is not going to be better. Plus, if this keeps growing over cornea, it's going to affect the vision. So no matter how cataract is going to be taken care of and the nice and clear lens implant is going to be placed, vision is not going to be improved. And once again, there are beautiful treatments out there these days with topical drops that has been shown to be the 5FU has been shown to be very helpful in resolution of such lesions. So we always want to do it prior because we don't want to also seed or spread the tumor cells on the surface of the eye before moving on. In summary, cataract evaluation requires detailed and complete eye examinations, and I hope by now you know why that is very important. Some patients had a cataract evaluation, like let's say a year or two ago, and they call and say, oh, we're ready for cataract evaluation, cataract surgery, and the cataract evaluation is done. Well, you need to be seen. Honestly, once it's like about 3 or 4 months from the last time that you were seen and you want to go ahead and have cataract surgery, you need to be seen prior. And the reason is because your dryness needs to be checked, your overall cornea health needs to be checked, not to mention that the health of the retina and the nerves are also very important as well. So finding existing cornea conditions in a timely fashion and treating prior to cataract surgery will optimize your visual outcome. And we are living in the era of available advanced technology. Knowing and addressing pre-existing cornea conditions will lead to choosing the best available technology that will give you the best visual outcome. And thank you. And I'm happy to answer any questions.
Yeah, we'll open it up at this time to questions. And if you're anything like me, where it'll take some minute for all that information to resonate and you come up with questions moving forward in the upcoming days or even weeks, you can always feel free to reach us at the same email that you registered with, the marketing@harvardeye.com. And we are happy to address those questions for you as they come to mind. Additionally, if after listening to that presentation that was very all-encompassing and very thorough, and you forgot something that was mentioned, don't worry, this will all be available on our YouTube channel, and a link will be sent out as well. So you will be able to rewatch it, to have it for yourself on file. You can share it with friends and family, etc. So that will be accessible through our YouTube channel as well. And it does look like we have our first question of the evening. And is that, should a patient with Alzheimer's be considered differently than a usual patient?
Well, that's a very good question. Of course, when we have patients who may not be able to understand every single thing that we discussed during the cataract evaluation session, and also they are having a hard time to making decisions for themselves in regards to what they are looking for, we usually want to give them the best vision potential with the least amount of things that we put them through. So of course, I mean, with Alzheimer patients, least amount of surgical procedures, least amount of times that they need to come back and forth and be seen would be more convenient for them. Having said that, that doesn't mean that we should not do whatever is best for them, but for them, maybe simple way of improving the vision would be enough for them, rather than putting them through multiple different things to provide them with the best visual outcome. The best visual outcome between patients is different. So a visual outcome that a patient is looking for is not necessarily the same as their friend or their neighbors. So it is very important. I go over goals, daily activities, jobs, what my patients are looking for to achieve after cataract surgery. So of course, any single condition will affect how we treat our patients to provide them with the best visual acuity, best visual quality for them.
Yeah. The next question we have is, how does the light adjustable lens work? And I know you touched on it briefly, but maybe a little
Yes.
bit more how,
Sure.
I guess, how the vision is adjusted after the
Sure.
lens.
No, that's a very good question too. I just didn't want to go into too much of a detail about it because this, talk was really, outside of the scope of that. But the lens adjustable lens is a beautiful technology out there. In order to place it in the eye, there's not much of a difference for the surgeon. The difference will be after surgery, we see patients just to monitor for the expected healing process. We wait about 3 weeks or so, making sure that both eyes are done, and our optometrists see the patients. They do the refraction or the prescription check for the eye, meaning if patient needs to have any kind of a tweak to see as good as they would like to. And then with about 3 to 5 sessions, we see patients in the office and dilate their eyes. And then we put them at the machine that I showed you. And then we give that UV light readings to the lens implant. The UV light would reshape the lens and then will give you the sharpness or fine tuning that you need after surgery. So overall, patients will see better already after surgery. But that's the fine tuning part that we can do after light adjustable lens to give them with the best vision that they're looking for.
Another great question, kind of adding on to the LAL, since it is an out-of-pocket expense, are the adjustments also out of pocket, and how many adjustments are needed?
Adjustments are all included in the package. You do not need to pay for those. That all you pay is including all those sessions, and usually somewhere between 3 to 5 sessions of treatments, we'll see all of them will be free. Post-op care is not going to be charged. I hope that helps.
Yeah.
Okay.
And it looks like that is the questions for this evening. And like I said and mentioned, if anybody does have any questions that pop up, down the road, feel free to reach out. We have our doors, phones, and emails open. So you're happy to go ahead and send those over. We're happy to assist you. But I guess before we take off for this evening, any last words, Dr. Rouhani?
Well, that's it. I would be happy to, answer any questions of any patients, please reach out. Thank you everyone for joining us tonight. I think there is another question.
Yeah, I just saw one more question pop up, and that is, I have my left eye as a regular lens. And I'm assuming the question is, can I have a different lens placed in my right eye, or an LAL, or a premium option if I so choose?
Yes, there are conditions or cases that we can use one like standard lens in one eye, and then the other eye can get premium lenses. However, having said that, we need to evaluate the overall health of the eye and then make a decision whether the patient is a candidate for a multifocal or light adjustable, or some sort of a premium implant. So overall health of the eye determines whether you're gonna get another type of an implant in the other eye. But the answer is yes, you could be a candidate for.
Yeah, and like I said before we sign off, Dr. Rouhani, we appreciate it. Thank you everybody for joining us this evening. We really appreciate you spending your Wednesday night with us. We appreciate you, and we are willing to help out with whatever concerns might come. So don't hesitate to reach out to us. And we wish you all a great rest of your Wednesday evening, and we thank you for joining us. Have a great evening, everyone.
Thank you, everyone. Have a good evening.